all of those numbers that I've referenced in the first slide, and we're just trying to consolidate everything under one roof, so to speak. The CTR has three main efforts that we undertake. One, we have a multi-center biorepository. That means that we consent patients, take their tumor samples, their blood samples, their associated EMR records, path, any film studies that we get, and that's all collected in-house for use for things like biomarker discovery projects or collaboration with external providers. We have a certified laboratory where we do patient testing in-house. We also do in-house biomarker discovery for intellectual property discovery. We also have a Center for Healthcare and Innovation, and that's more along the lines of telemedicine, so I'm not going to touch on that too much for this talk. And of course, all of this involves biostatistics, data analytics, and I'll show you a little bit later why that is such a large part of what we're doing. So I assume that a lot of people have heard a little bit at least about what a biorepository means, but I'll give a little bit of introduction of what it is. This is just a system where we're able to save some of these tumor samples for a prospective analysis. And a lot of big hospital systems are initiating these types of projects right now. We're sort of unique in that we have full-time employees embedded in each of our hospital systems whose only job is to ensure quality of the samples across every step. In general, what these systems look like, what these biorepositories look like is a physician will extract, will do a surgery, patient's been consented, the tumor sample will then be handed off to pathology. Pathology does something to it that you never really know what it is. And then eventually you get back a tumor sample which may or may not be high quality because it may or may not have been left out on the shelf overnight. And then you store it as best you can. In our system, we try to take out the guesswork there. There's a person who actually follows every step along the way. So I know how long it's sat in pathology. I know, was it at room temperature for any length of period of time. The important part for this, though, is that we can associate all of these samples with the electronic medical records of those patients. And that's something that only in the last few years has become possible. So if you have a huge tumor bank of 30,000 samples, for example, and you have a rough idea of what type of tumor it is, but you have no idea what those patients were treated with, you have no idea what their outcome was, you don't know how long they stayed on treatment, those samples aren't worth a lot. You can do some basic biomarker discovery projects with that, but there's no way for you to really drive towards things that will influence patient survival, for example. So sort of as a mock-up cartoon here, I just wanted to show you what is actually involved in these sorts of studies, where you take, in the operating room, say for instance a lung cancer sample from a patient who's consented. That'll be removed surgically, and we get it trisected generally. So you've got what's called a formalin-fixed paraffin-embedded block at the top and bottom section. And those are sent to pathology for normal standard of care operations. That's usually a pathologist making a reading on the sample and telling the patient how aggressive the tumor looks like, things like that. And the center sample is fresh frozen. That means we freeze in liquid nitrogen. So we try to snap freeze it as quickly as possible so the tumor doesn't undergo any sort of biomolecular changes. They start to degrade very quickly as you remove a piece of tissue from the body. Within 30 minutes, there's changes that have begun in any tissue after surgical resection that make it increasingly difficult for people like me to look at the tissue and tell you something that's relevant to the patient. I talked a little bit about this before, but each of our individual hospitals, so that's 86 hospitals right now across the US, each of those has their own electronic medical record system. It could be Epic, Meditech, name your flavor. We probably have it in our hospital system. But that means that if you're a patient, you go to one of our hospitals, then you go to another hospital, there's no clear way for your medical records from one hospital to transfer to the other hospital. We, in fact, have to generally courier it, unfortunately. So to get around that obstacle is the purpose of what we're calling OneCare, and that's a overall system that's going to draw from each of the EMRs. So your hospital record will be available across the entire system. Now, this is not a trivial matter. It involves about $1 billion investment right now and is about 2 years behind schedule, just because of all of the data siloing effects that we encounter. And I think CHI itself was probably a little naive when we first embarked on this. We thought that this would be a little bit smoother. We probably underestimated the complexity of some of the data that's in there. So just to give you an idea then, for each of those hospitals, probably a standard test that's ordered, like your blood triglyceride level, has been entered 86 different ways into the hospital systems. And making sure that that's readable into this OneCare system is a huge challenge. And that's something that's still progressing, and hopefully we're going to start seeing rollout now to some of the sort of alpha and beta sites. But that becomes a huge tool, of course, because then instead of going to each hospital and asking for records for patients that are in our biorepository, you can just go to one central site and draw records and look at overall things like what's overall survival in our hospital system, how does that compare to everybody else's hospital system, what's our reimbursement rate, how are the readmission rates, what's the secondary infection rates. So unlike MedStar, who I think is very clearly used to innovation, or at least you guys have a good sense for it, some of our hospitals, a majority of our hospitals, I should say, are community-based. These are not teaching hospitals, they're not research hospitals. Most of the physicians have been there for upwards of 20 years, probably 10 to 20 years. And a lot of what we end up doing is what we call physician engagement. So you have to educate physicians into what these personalized medicine things actually mean for them, mean for their patients. What are the potential downfalls of it? Since most of what we do is genomics based, so these are things that have come out of the Human Genome Project. These are not, in general, most of our physicians have not had a genetics course. So we do a lot of teaching as to what a different frequency of mutation would mean to the patients. How does that influence the treatment that you should be giving these patients? And all of this that I was just discussing about is part of what the CTR calls our Discovery Research Network, our DRN. So that includes the biospecimen collection, includes the research in the translational laboratory, which I'm obviously quite involved with, hypothesis development. So as Sarge talked about a little bit before, we're not interested in general in partnering with people outside of our network. CTR was built with the mission to drive this internally in the CHI system. So we do have some partners in pharma, for instance, but that's secondary to our primary mission. And what we really try to drive is personalized medicine uptake in the system. So that gives us a bit of a different view. We're not really concerned with what's happening across the whole health system. We're just really focused on what happens in our community-based hospitals. So I'm going to get a little bit more into what we actually do. Please stop me and ask any questions if I go over this a little too fast, or there's terms here that you don't recognize. I'm used to giving this part of the talk mostly to scientists in the lab, so I apologize if I use any acronyms that you guys may not be familiar with. But currently, and I don't know how much exposure all of you have had to this, but currently the big push in personalized medicine is what we're calling next-generation sequencing. So this is DNA sequencing of either the patient or the patient's tumor, or both, that's being carried out on platforms that are derived or descended from the Human Genome Project. So these technologies, by and large, were initiated in that project, and we're taking advantage of the third or fourth generation in some of these cases. That project took a huge amount of time, many centers, working collaboration, hundreds of millions of dollars. Right now, currently, I can take a tumor sample and do a whole genome sequencing. That means I can understand every bit of DNA in that tumor sample. Turnaround time right now is 3 to 4 months, and it costs me about $4,000 to do the actual sequencing. So that's the sort of rapid decrease in cost and time that we're facing. And that curve is still going. So when people talk about a $1,000 genome, that means you can send your sample and for $1,000 understand everything that's going on in your DNA or your tumor DNA, for example. We're rapidly approaching that. And in some cases we've reached it, although there's some caveats there that I'll talk about. One of those caveats is what we know as the data tsunami. Very quickly, the analysis of the sequencing and the storage of the data that's produced by that sequencing is becoming more costly than the actual sequencing. For example, about a decade ago, what we would traditionally do in the lab would be we would sequence one gene, and we would understand if there was a mutation in that gene and if that was a good potential target, therapeutically speaking. What you get out of that is a file that's about the size of a typical Word or Excel file, 10 to 100 kilobytes in size. Right now, currently, we routinely do full exome sequencing. That means we sequence a percentage of the genome that is responsible for making all the proteins in your body. That produces about 10 gigabytes of data per sample that we sequence. So if I sequenced your tumor and yourself, and they're completely different genetically speaking generally, not completely different, sorry, they're marked differences genetically speaking, then you get about 20 gigabytes of data that you have to deal with and you have to store. Now if I do a full genome sequencing, that's 100 gigabytes per sample. And that data you have to sort through and you have to figure out what you're looking at. So you can see here that this is rapidly becoming the bottleneck. And then the accompanying data analysis is very time consuming. It generally takes more time now to annotate this data into something that's a readable report for a physician than it does for me to sequence it. Does that make sense to everybody? So, as you can imagine, the second you start seeing things like that, people start trying to come up with solutions. There's a bunch of different companies right now that are starting to compete in this area. They're trying to offer their services where they will take the raw data that you send from the sequencing and give you something that's actually a readable report, giving a target for a physician to go after. One of these companies we've partnered with in sort of a test phase is called Transmed, but there's a couple other options as well, so I'm not endorsing Transmed here. I just wanted to be careful about that. So the goal, obviously, is that if you do your sequencing from a tumor and send it off, and you spend the thousands of dollars to do that, the additional thousands of dollars to do the analysis, you want a target that you can go to your physician, or I can send this report to the physician and say, this patient should be on this drug because it's actually targeting that tumor. They shouldn't be just given a broad range chemotherapeutic, or they should be given the chemotherapeutic with this drug in addition. That's also a possibility. This is only possible because we're getting more and more of what we're calling targeted treatments in the clinic. So these are treatments that hit a particular molecule in the cell, but that molecule has to be either activated or mutated. So it has to be a logical target. You can't just start giving this to everybody. And the sort of report that you generally get out is something like a treatment summary report that's shown here. So there's a drug here called imatinib, which is a targeted therapy. It has a relevance in one particular tumor type. This tumor type is currently being reimbursed for this treatment. However, this tumor that I'm showing you right now is not this tumor type. This would be considered completely off-label. So there's a lot of questions that start coming up then. If you're going to give an off-label drug to a person, but there's a logical reason for giving it to that person, who's going to reimburse that? The payers aren't. They have no incentive to do that right now. Who's going to be responsible if there's a side effect that could be fatal, for instance? Physicians don't want that burden. We don't want that burden in the lab, certainly. So there's a lot of questions here that we're just sort of cautiously tiptoeing towards. These are not trivial questions, and as you can imagine, these can have really profound effects on our patients. So I think that a lot of people have just sort of started to say we have to really take a step back and consider some of these effects. Another side effect of this, so to speak, is that you can then identify the patient that is in your care or that you've seen that is a good fit for a clinical trial that may or may not be enrolling within, say, you can define an area of 100 miles. And since we're within 100 miles of the NCI, most of these trials are being run in Bethesda. For instance, the patient that I just showed you would be a good fit for, or meets the eligibility for being included in a clinical trial targeting c-KIT that's run out of NCI Bethesda.
So this report goes back to the doctor showing which clinical trials are available
Yes.
in their area to possibly.
Yeah, and that's actually of more interest to our physicians than the first report that I showed you.
Right.
They have a set, you get a patient with lung cancer or non-small cell. You have a very clearly defined treatment protocol right now. You give them a platinum-based therapy, resection, you may target them, might be trauma, whatever. But if they fail all of that, which a large percentage do, unfortunately, then the physicians like this, or at least those that we've started engaging with, really like this because then they have an option of a clinical trial that they can offer the patient. So that's something that I think is going to become more and more interesting, especially for our physicians. There's another component to this that you can also show to patients, although this is starting to get towards the point where people start getting uncomfortable, is you can show them what other patients with a DNA in their tumor that's similar to what we sequenced, how they did, and what sort of side effects they experienced. The problem there is if this tumor was very aggressive and these patients have very poor outcome, do you really want to show that to a patient? Are you taking away their hope? Are you telling them that they have cancer which cannot be cured? There's some questions there that we're also starting to grapple with. So the challenges for next generation sequencing, so of course with any new technology, and this is being called a disruptive technology for what it's worth, there's always hurdles that are sort of glossed over in the first few years, and then everybody starts realizing it's never as simple as we think it is. Standard of care right now is not to take a fresh biopsy and send that out for sequencing. You always send that to pathology first. Pathology does what they need to do to verify that it is cancer from the biopsy that the patient has undergone. And that sample is generally what we call fixed. It's put into formalin and it's embedded in paraffin. Now, that does unfortunate things to the DNA. It makes it harder for us to get good quality DNA out of it, and it makes it much harder for us to get a lot of DNA out of it. So there's some input requirements for next generation sequencing that are making it difficult for us to make this part of the standard of care treatment. Although there are places like Baylor, MD Anderson, who are really pushing towards making it where every patient that comes in the door has their DNA sequenced. As you can imagine, this is a huge requirement. You can't just hand back a 40-page report to a physician. They don't have the time or interest to look at that, nor will they ever. And who's going to pay them for that time? So you need like a 3-page report And the first page, the top of that first page, needs to give a very clear indication of what this patient can be treated with and why. And then everything else should be supporting documents. But how that's actually laid out is something that a lot of people are still battling over. Our current turnaround times, even though they've decreased to 3 to 4 months, that's still too long. We need to aim for a turnaround time of 2 to 3 weeks. So there's a lot of improvement that needs to be worked into that as well. Of course, the opportunities for this sort of technology are, this is actually true personalized medicine. If you can take a patient's sample and tell a doctor immediately what targeted therapy would work on them or should work on them, then that's something that's of great interest and value for our system. You can use less material instead of doing all these multiple tests. Patients usually go back for second biopsies in some cases because you don't have enough tissue from the first one. Obviously, you don't want to do that if it's something like a lung biopsy. What we really want to push towards is where you can start following a patient longitudinally. So you can take a sample of the primary tumor, you can take a sample of the relapse that they may have, and then metastasis, which is where it disseminates from the primary tumor, and you can tailor the actual treatment along the entire progression of this disease. And this is becoming absolutely more necessary as FDA mandates that clinical trials include a biomarker part to them. And that's something that FDA is really starting to push towards right now. I thought it would be useful to give you an actual practical. Do I have a couple more minutes? Okay. Well, we'll just say that this is one of the targets that a lot of big drug companies are going after right now. It's called EGFR. This is the cell, sort of a simplified diagram of the cell, and this is the target molecule that signals the cell to keep growing. So in cancer, anything you can target to stop a cell from growing, sort of simplistically, that's something that everybody starts going after. Now, the reason that you don't want to give this treatment to everybody is that a typical targeting, specific targeted treatment to EGFR, for example, costs around $30,000 for 8 weeks. So if a patient is on that for a whole year, you can tell that either the patient is going broke, the hospital system is going broke, or the payees are going broke. In some cases, CHI is the payee, so we have twice the incentive to keep this from happening, unless there is a good outcome to the patient. So I'll just end there. If there's any other questions, yeah, please.
Beyond just tumor genomics, are you familiar with the work that Michael Snyder's done at Stanford? How you're able to analyze, what are you talking about, right? Be able to, if you have all this data, are you able to combine it with environmental factors at some point and be able to do some?
Yeah, unfortunately, everything you start layering on top of that data just exponentially increases the complexity of that data in regards to noise, for example. And that's not something we have even started to touch. We're still in the 100 gigabytes of data and trying to really sort through that efficiently and give a good, concise report. And then once you have that, then you can start easily, or not so easily, but you can start layering on additional information on top of that.
But you have this data warehouse already, right, somewhere?
Yeah, we do have an in-house data warehouse. Unfortunately, it's again siloed, so that's another challenge, is how does everybody share that data if necessary.
Santosh, how big are your image files?
They can easily reach up to gigabytes.
Gigabyte to 100 gigabytes, correct? You go bigger than 100 gigabytes?
Not usually. That's
No?
pretty big.
Oh. Well, thank you very much, Jean-Claude.
Thank you.
And finally,